edition NPRM. Today on today's call is Michelle Knighton, our testing lab manager, and Kevin Brown, our security specialist. And my name is Amit Trivedi. I'm the program manager here at ICSA Labs for our healthcare program. And again, I apologize for those delays, but let's get started and get through this webinar. We're hoping to provide a little bit of information today on the 2014 edition of the NPRM for certification standards and criteria for meaningful use. After today's webinar, you should get an overview of the NPRM, some of the new concepts that are introduced for 2014, and as well as an overview of the new revised unchanged criteria and the introduced standards for content exchange, vocabulary, transport, functionality, and security. We'll also talk a little bit about the next steps and how folks can continue to stay involved in this NPRM process and provide additional feedback to ONC and work with ICSA Labs in this transition period. We've designed this webinar to be informational, so hopefully you'll get a lot out of it. We also are taking some Q&A at the end of this presentation, so feel free to submit any questions that you might have. We also have a couple polls that we may be interjecting throughout the presentation, so if you can, please provide some additional feedback for us, as that would be helpful. And hopefully you can follow along on this live meeting. So with that, let's get started and talk about the 2014 edition of the NPRM. So the ONC Health IT Certification Program was developed to define a process to ensure that EHR technologies meet the adopted standards, certification criteria, and other requirements to help support providers and hospitals as they try to achieve meaningful use. ICSA Labs is an authorized testing and certification body, or ATCB, under the temporary program, and is on track to be authorized for the permanent ONC Health IT Certification Program, which is slated for summer 2012. And to date, ICSA Labs has certified a number of products ranging from complete ambulatory and inpatient systems, HIEs, specialty systems, and hospital sites. This is the Meaningful Use Program Vision and Goals, straight from the CMS and ONC websites. And the vision and goals should be supported and reflected through the different criteria that we're testing against. And so the vision of meaningful use is to enable significant and measurable improvements in population health through a transformed healthcare delivery system. And the goals of improving quality, safety, efficiency, engaging patients and their families, improving care coordination, improving population and public health, and ensuring privacy and security protections are all reflected in the various testing procedures and criteria found in the NPRM. Now, the Meaningful Use program is set up to be in 3 stages, and each stage also involves significantly raising the bar. And we're in the tail end of stage 1, and the main point around that particular stage was getting folks to be able to get to a point where we can capture data in coded formats. Now we're approaching stage 2, which we'll be in for an expanding of the exchange of clinical information in these structured formats. And the goal is to get to stage 3, which will be using the data that we've been exchanged to really drive some of that improvement in care coordination and healthcare delivery. So the 2014 edition NPRM was released just about a month ago, and in it are a number of new certification concepts. And so one thing to keep in mind as we go through and describe some of the items in the NPRM, and the NPRM stands for Notice of Proposed Rulemaking. So one thing to keep in mind is these are all proposals. Nothing has been finalized yet, and that doesn't happen until the final rule is published and goes effective. And so the period we're in right now is the public comment period, where folks, the public, are supposed to be digesting this information and providing additional feedback back to ONC and CMS. ICSA Labs, as an ATCB, will be providing pointed feedback on specific criteria and possibly around testing procedures. But as customers and stakeholders of this program, it's also important for you guys to be able to get your voice heard And whether that's by submitting your own individual public comments or also passing on your comments to us so that we can also provide them to ONC, I think it would be helpful and something that they would be looking for in terms of getting direct feedback from stakeholders of the program. So when an ACCB provides public comments, it can be helpful. And when we can frame it to say things like, this is what our customers feel, or these are their concerns, or these are things that they seem to be looking forward to, I think that can add additional weight to the discussion. So the 2014 edition NPRM introduces a number of new concepts that impact the certification program. One of the most basic ones is the changing of the name from the temporary and permanent certification programs to now the ONC HIT certification program. Another change is the description of stages and criteria. Meaningful use will continue to be described in stages. However, the specific certification criteria are being changed in description to 2011 edition, which would constitute the certification criteria that most of the folks on this call are certified against. And what are being proposed as the Stage 2 criteria will now be called the 2014 edition criteria. Now, this change in labeling should not affect any previously certified products. There may be new labels that come out with the new program and the permanent program. But a lot of that information is yet still to be seen as far as how this will all play out. But at the moment, the proposal on the table is to rename the criteria and along the lines of 2011 edition, 2014 edition, etc. One of the other major big changes in the NPRM is the revised definition of certified EHRT. That's the CEHRT. And we'll be going into that in more detail in a few more slides. The NPRM also allows for newer versions of adopted minimum standard code sets and allows for folks, especially vendors, to be able to adopt the newest and most updated code set instead of being stuck with the code set that's specifically referenced in the final rule. The NPRM also proposes to eliminate the certification requirement that every EHR module must be certified to the privacy and security criteria. And that privacy and security, those privacy and security requirements have now been moved to the definition of a base EHR, which we'll be covering later in this presentation. And then another proposal in there, which I think folks on this call might find interesting, is that test results used for the EHR certification are being proposed to be made publicly available. And this is something new. In most of the certification efforts to date, the only information that's been recorded has been what criteria have passed, not what criteria were applied for or failed, just what passed. And so this could be a new wrinkle in the plans in terms of making the test results public. It is an attempt to make the testing and certification process a little more transparent to purchasers of EHR technologies. And then another item is that certified EHR technologies must only be possessed to support the functions that the eligible provider or eligible hospital is attesting to. This is another big change as opposed to having to buy everything or possess all of the technologies that cover a complete EHR from A to Z. But we'll be discussing that in more detail as well. And finally, they introduced the idea of gap testing, which would allow for folks who had certified under the 2011 edition criteria to be able to verify that their criteria are still intact without additional testing for those criteria that remain unchanged for the 2014 edition. There are also a number of high-level revisions that were proposed in the NPRM, and these range from removing the marketing statement around guaranteeing the receipt of incentive payments. Those of you who have designed press releases or have been involved in marketing or certification are probably familiar with that particular statements. There are other requirements around using the addition of the criteria that have been certified on all marketing materials, so that could be a change going forward for folks who are certified under Stage 1. And since instead of using the 2011, 2012 compliant or 2013, 2014, the changes proposed is to use the 2014 edition label. Replacing the term modify with change, you'll see that in a lot of the proposed criteria, as well as replacing the term retrieve with access, and a couple other terminology changes around the meaning of incorporate, replacing the term generate with create, and a new term transmit as opposed to submit when talking about moving files from one point to another. So we are going to talk a little bit more about the base EHR and what eligible providers and eligible hospitals need as a minimum to be able to attest for meaningful use. However, ONC feels that it will still be important for folks to certify as a complete EHR. And one of the main reasons is purchasing clarity. For purchasers of a complete EHR, they know that this is all they need to make meaningful use. They have the technologies once they've made that purchase. It's additional assurance to eligible providers and hospitals that the EHR technology meets the regulatory definition of certified EHR technology. And it will support the eligible providers and hospitals as they attempt to achieve all of the meaningful use objectives and measures, as opposed to just the meaningful use objectives and measures a particular provider or hospital would be attesting to. Another reason why a complete EHR might be a helpful label is that it ensures purchasers that all the capabilities have been tested and certified to work properly together. As those of you who have done modular testing and certification know, the modules are not tested for interoperability or how the modules work together. They're all set up as one-off tests. And that won't be changing too much as far as we can tell for the future stages or the 2014 edition of testing. However, that being said, the test procedures have not been published yet, just the criteria. That's part of the next steps. And we'll definitely be monitoring all of that as the testing procedures are being formalized. Finally, the one other thing about a complete EHR is that providers and hospitals that purchase these systems do not have to assume the responsibility of determining which EHR modules include the capabilities they need to support achieving meaningful use, or it removes the burden of ensuring that all the different modules work properly together. There's still a bit of buyer beware when folks go the modular route in terms of assembling the complete EHR technology they need in their particular setting. So another new proposal in the NPRM is adaptions to certified EHR technology. So adaptions do not require certification if they're including the exact same capabilities in the certified complete EHR or EHR module. And so an example of an adaptation is listed on the slide below. So if we had a certified EHR technology capable of running on a tablet device or a smartphone, it could include the same capabilities of the certified EHR technology to prescribe, to take electronic notes, to submit immunization messages, etc. As long as the certified technology is exactly the same, the proposal here is that adaptation should be covered by the certified EHR technology certification. And that's something that we'll be curious to see how that plays out and what kind of comments are solicited from the public. On one hand, it definitely gives vendors a lot of flexibility when porting systems or technologies to different hardware, but on the other hand, there's definitely a question as to whether this ported software would have that same functionality. It sounds like what ONC is proposing is attestation around this particular item. So one of the major things, as I mentioned earlier in the NPRM, is the revised definition of certified EHR technology. And so for meaningful use stage 1, the idea was that all eligible providers and hospitals had to have the EHR technology that has been certified to all of the applicable 2011 criteria for certification. Now, for 2014, the change is that all eligible providers, hospitals, must have the EHR technology, including a base EHR, that has been certified to the 2014 edition EHR certification criteria that support the objectives, measures, and their ability to successfully report the quality measures for the meaningful use stage that they seek to achieve. So this is closer to only buying the technologies and the pieces of the EHR that you need to attest to meaningful use, as opposed to having everything. One of the common complaints and criticisms in stage one was from specialty providers. Say you didn't do e-prescribing, and this one came up often. Folks needed to have that e-prescribing technology. They needed to purchase it, even if they didn't use it, even if it wasn't part of their meaningful use attestation. And as you can imagine, that drove some people up the wall. And there were many, many comments from ONC along those lines. And it seems that ONC has heard those, and it's reflected in the NPRM. Which goes back to what I was saying before about being able to provide feedback to ONC. For those of you who have been monitoring the documents in stage one, you probably noticed that the proposals from the health IT policy groups and standards committees and the final rule and even the interim final rule were vastly different. And there were some comments and criticisms as to how much were folks listening to what the proposals were or what the suggestions were from the committees. That being said, at the same time, there was definitely a time crunch to be able to get everything done at once. But this time around, going through the NPRM, I think it'd be safe to say that ONC had definitely been made aware of many comments, and when possible, they tried to change things for the better. So I'm going to talk a little bit about public comments a little bit more at the end, but one thing I want to reiterate is that it's important to supply those public comments as stakeholders to this program, both positive and negative comments. If you have something you don't like, let them know, but if there's something that you do like, and I think this proposed revision of definition of certified EHR technology is something that many people will like, please make sure to pass that information on to ONC. And so this slide also gives you a little bit more of an idea of what a base EHR, how it's defined and what are the proposed 2014 edition criteria that go along with them. So your base EHR will contain the functionality for being able to record demographics, vital signs, problem lists, medication allergy lists. It would also have capabilities for drug allergy interaction checks, clinical decision support, CPOE, clinical quality measures, transitions of care, the ability to view, download, and transmit information to a third party, and the privacy and security components. And once again, this is just another definition of the certified EHR technology, kind of building on the slide that we just had. These are the building blocks of the base EHR and the additional EHR functions that are required. And with that, we're going to next take a deeper dive into the actual 2014 edition criteria. And Michelle is going to walk you through the various criteria and point out what's new, what's been revised, and what's been unchanged.
Great. Thanks, Amit. Can you hear me okay?
Yeah. Okay.
So before we get started on the deeper dive, we just wanted to do a little bit of interaction with you and get your feedback on a couple of poll questions. So the first poll question that I am going to put up is whether you have any products or iterations of products, maybe additional versions, maybe you're a complete EHR and you now want some EHR modular certification. So we'd like to know, do you have any other products that you intend to certify under the 2011 edition criteria? So we've got yes, no, and maybe up here, so we'll give you just a few seconds to respond to this one. Okay, still getting just a few responses in, but It looks like about 50% of you say no, and the other 50% say yes or maybe. So that's really good, helpful information for us to have. So the next question that we just want to ask then is, if you said you intend to certify, when do you think you're going to want to do that? Is it going to be May of this year, June, July, or are you thinking maybe August or later? Okay, great. So it looks like about, a third of you want to do maybe May, no one is interested in June, and maybe 20% in July, and about 40-some% in August. So thank you. That really helps with our planning process. So next I want to go ahead and turn it back over to the 2014 edition criteria. And we are going to do a deeper dive now on the proposed updates and revisions. So the first thing that I want to talk about, and I know that everyone is really interested in, is gap testing. So this, of course, the ONC recognizes as being a much less costly, more efficient certification option, and they provided some pretty clear definitions of what would be eligible for gap testing. For example, any 2011 criteria that meets the definition of unchanged, and we'll go through that definition in just a moment, but if it's unchanged from 2011 to 2014 edition criteria, it's eligible for gap testing. So that means you can use your current 2011 test results and submit them to the testing body to show compliance with 2014 edition testing. So that would mean you would be exempt potentially from testing against that criterion under 2014. But keep in mind that there's no possibility that you could come through 2014 edition testing and get certification without actually doing some level of testing. So all EHRs would be required to certify at a minimum 170, 314, G1, G2, or G3, and all three of those criteria are related to both automated measure reporting for both percentage-based and non-percentage-based measures. So there will be some level of testing that you will have to do, but if you already tested against 2011 criteria that is unchanged in 2014, you should not need to test it again. Under 2014 edition criteria, under the permanent program, you now have to make sure you're using an ONC authorized testing lab that's been accredited by NAVLAP and an ONC authorized certification body that's been accredited by ANSI. And I know Amit shared with you that we're already in the process of attaining those authorizations. The next slide that I want to go over is related to the criteria type definitions and give you some examples of those. So basically we have unchanged, and that's with and without enhancements. So there are some criteria that have been modified slightly, and they're calling them enhancements, but still saying they meet that definition of being unchanged. So that would be, for example, they have the exact same capabilities. The capabilities apply to the same setting, or it's been redesignated as optional for the same setting. And when they talk about settings, they're talking about either, the ambulatory or the inpatient domains. So, for example, CPOE is a criterion that has enhancements. However, it still meets the definition of unchanged. For revised, a really great example would be when maybe multiple terminologies were allowed previously under 2011, and now they have redefined that and revised it. So, for example, patient problems, right now you can use ICD-9 or SNOMED CT. Under the 2014 edition, they will only allow you to use SNOMED CT. So you would have to come back and retest if you used ICD-9 under 2011. Under the new category, this would be capabilities that either have never been included in either domain, or it was previously listed in one domain and not the other. And a great example would be e-prescribing. E-prescribing right now is only applicable to the ambulatory setting, but they are now saying that it is a new criterion for the inpatient setting. So for ambulatory, it would be a revised criterion because they've changed some of the standards that are allowed, but it is a new criterion for inpatient testing. On this next slide, we talk about the certified EHR technology and what constitutes a base EHR. These are all of the criteria, and we've tried to color code these so that you have a clear understanding of which criteria are unchanged, new, or revised. And I'm not going to go into a deeper dive on this, but just know this is here. You can also find this in Table 6 in the NPRM. We have certification core categories now under 2014 edition. So we have clinical criteria, care coordination, CQM, privacy and security, patient engagement, public health, utilization. So under each of those main core categories, there may be one or more additional criteria that specifies what those requirements are. So under the new 2014 edition, we have 51 total criteria, and we still have that one additional optional accounting of disclosures criterion and privacy and security. And you'll see that we still have 9 criteria. However, they have combined some of the criteria and then implemented new criteria, but there's still a base total of 9 privacy and security criteria. Next, we want to go through the new criteria in both domains. So in the ambulatory and inpatient domains, we have electronic notes, imaging results, being able to record family health history as structured data, and they've defined that as being related to a primary relative, so someone who shares 50% of your genes. They've also proposed a new criterion related to amendments and being able to protect information once it's been entered into the EHRT. The next one is being able to view, download, and transmit to a third party. And we saw this a little bit in a couple of the criteria under 2011 edition, but they have formalized it. It is now one criterion meeting both domains. There are 2 different objectives depending on whether it's an eligible professional or eligible hospital. You'll note in eligible providers there's that requirement that it is available within 4 business days, whereas in the hospital it simply is more general and says that it needs to be able to be viewed and transmitted online for a hospital admission, and there's no time frame associated with that. For automated numerator recording, this should not be confused with automated measure recording, which is what we have now under 2011 edition. This is specific to systems, EHR modules, that can automate the numerator recording. So you'll see here that we have 170, 314, G1, G2, and G3. So if a system is certified under G2, which is automated measure calculation, then they do not need to certify against G1, so they would be exempt from that. And complete EHRs would need to be certified to G2, which is the automated measure calculation, not automated numerator recording. So this criterion is really just specific to EHR modules that want to get certified. The next one is the third one that I just talked about, G3. This is for non-percentage-based measure use reporting. And if a technology is getting certified in any of the criteria listed here, they must get certified under G3. So there's no exemption here. If you're doing, any sort of transmitting, EMR, patient list, drug formulary, clinical decision support, or interaction checks, your system must also be certified against this criterion. The next one is safety enhanced design, and that's just a really fancy way of saying usability. So you've probably noticed that NIST has released some information about usability, and so that's something that you should really pay attention to. Certified technology has to certify in this criterion if they're also certifying under any of the criteria that are listed on this slide. This testing would be done via attestation, so you'd simply fill out a document and would need to attest to all of the data elements that are listed there in that NIST document. And Amit spoke earlier about test reports being made publicly available. This attestation would also be available publicly. ONC has implied that they will provide guidance on the information that's going to be required to be listed in the test reports and how these attestations must be presented to the public. So that's something to keep in mind when you're formulating your public comments. There are two additional safety-related criteria that have not been, of course, formally adopted, and they are simply asking for public comments on these. And that is, the first one is related to quality systems. So ONC wants to publish a life cycle development and quality management document for EHR systems. And again, if this was adopted, this would be via attestation. You wouldn't be required to comply or not comply. It's more of a provide documentation so that we can see where you're at and where the market is at. For patient safety events, the purpose of this is to report adverse events to patient safety organizations using the AHRQ common format. Next, I want to talk about the three new criteria in the ambulatory setting. We have secure messaging, which is a baseline standard for encryption and hashing algorithms. And those are the algorithms identified in FITS 142 Annex A. And so that's being able to communicate securely with patients regarding their health information. The next two criteria are related to cancer reporting, so both the identification and reporting of cancer cases, as well as transmitting that data to a state cancer registry. So those are two brand new criteria, or three brand new criteria in that domain. We also have three new criteria in the inpatient domain. We have EMAR, e-prescribing that I talked about earlier, as well as the ability to transmit lab test results and values to ambulatory providers. So the intent here is to provide structured data from the hospital setting to the eligible professionals. Next, we want to look at revised criteria. So these are criteria that currently exist in 2011, but have been revised in some way. And we have a lot of information on these slides, and we will provide this in some format to you later. So I'm not going to read these verbatim to you, but just go through some highlights. The first one is drug-to-drug and drug-to-allergy interaction checks. They have eliminated the ability for the technology to allow users to adjust drug-to-allergy interaction checks. So instead, they would just be modifying drug-to-drug interactions, and they have limited that to specify that it's the level of severity of those notifications that should be adjusted. For demographics, they have specified that ICD-10 must be used for recording preliminary cause of death, and that's a requirement in the inpatient setting. They've also made some other requirements about ISO 639-1 as the vocab standard for preferred language, and some other requirements related to that. Number 3, problem list. I believe I spoke about this earlier. Right now you can use SNOMED or ICD-9, and they are limiting that to only using SNOMED CT. We also have CDS. They are replacing the term CDS rule with CDS intervention, and they have asked us to more globally look at CDS intervention instead of looking at it as simply an alert, a notification, or an explicit care suggestion. They want us to more broadly interpret that as user-facing representation of evidence-based clinical guidance. This item is also one that's going to require that info button standard, so make sure you pay particular attention to it. For patient-specific education resources, again, the info button standard is being required for incorporate summary of care record, as well as create and transmit the summary care record. We now are required to use a consolidated CDA if this proposal is finalized in the final rule. So no longer a CCR or a CCD. Instead, we're going to do the CCDA. For clinical information reconciliation, you likely remember that right now we have a medication reconciliation criterion, and they have expanded that to say clinical information, and they want you to be able to now merge those individual data elements. So currently under MedRec, you're only required to compare two lists, not actually perform reconciliation, and they've seen that that's a bit misleading, and so they have proposed that for clinical information reconciliation, reconciliation is actually performed. For incorporate laboratory test results and values, they've replaced some of the terms like attribute, associate, link, incorporate, and they've changed, the changes are only applicable to the ambulatory setting, although they have asked for public comments on whether or not the same requirements should be applied to inpatient setting. For clinical quality measures, you need to be able to capture and export that information, and the data has to be associated with the categories, states, and attributes that's represented by the quality data model. We have 2 additional revised criteria, both all relating to clinical quality measures. CQMs are no longer separated by setting. So under 2011 edition, we have 44 ambulatory criteria. We have 15 inpatient clinical quality measures, and they will no longer be separated. They're proposing that they be combined regardless of setting. We have a revised criteria regarding auditable events and tamper resistance. So the audit log has to be enabled by default, which is something new, and the enabling and disabling of the recording of auditable events has to be limited to an identified set of users. And you're going to see that terminology, identified set of users, throughout the criteria from the 2014 edition. For audit reports, an example implementation here would meet this criterion. They provided the ASTM standard for clinical encryption of data at rest. For this item, they have talked about stopping that information, and stopped would mean that the session has been terminated, including the termination of a network connection. So this could be demonstrated in one of 2 ways. Either the technology is designed to manage information on end-user devices, or they have to prove that the information never remains on end-user devices after use of that technology is stopped. And again, stop means the session has been terminated. For transmission to immunization registries, currently under the 2011 edition, we are allowed to use the HL7 2.3.1 message, and it's being proposed that that is limited to HL7 2.5.1 only. For transmission to public health agencies, the same thing, only HL7 version 2.5.1. And you'll note for both of these that they have some specific implementation guides that they would want you to use. The other revised criterion, automated measure calculation, and they simply want to clarify that the recording, calculating, and reporting applies to both the numerator and the denominator. So those would need to be automated. Right now there's a little bit more leniency in that for that criterion, so that is changing. E-prescribing, they are, CMS is retiring NCPDP script version 8.1, so this new criterion, revised criterion would limit it to NCPDP script version 10.6. And again, for clinical summaries, along with some of the other criteria that we talked about earlier, they will only accept the consolidated CDA. We have one revised criterion from the inpatient setting, and that is the transmission of reportable lab results. And so they've talked more about which standards are available and how those results get transmitted. That moves through all of the revised criteria. There are no criteria that have been revised only for, excuse me, let me back up. Next, we want to talk about the 8 unchanged criteria, and these are the ones that we have refinements on. So there are 8 of them. The base capability remains the same, but they've made some slight modifications. So, for example, in CPOE, they combined the ambulatory and inpatient criteria into one. There was no difference between them. They were just separated for some reason, so they've combined those. They've changed some of the language. For vital signs, they have moved growth charts as optional, and they've added an alternative term, length to go with height. They removed the age range reference, and for smoking status, they've again just replaced a couple of terms. So some very minor modifications there. For patient reminders, For this one, they want to anticipate that providers could use communication standards that are available in the EHR technology that is certified to some specific criteria. And again, this one is in the ambulatory domain only. We also have some revisions to authentication, access control, and authorization. Under 2011 edition criteria, we have two separate criteria, one for authentication, one for access control. They've combined those, made a couple of small changes, and it's now one criterion under the proposed rule. For automatic log-off, this is again unchanged. You need to be able to terminate the session, including terminating the network connection. Item number 7 is emergency access. They've just, again, replaced some terminology. There's that phrase identified set of users again. They've replaced that instead of using who are authorized for emergency situations. For integrity, NIST has indicated that SHA-1 is too short for secure digital signatures, but some systems do not or cannot support SHA-2, so they're actually seeking some specific public comments on whether SHA-1 should be replaced with SHA-2. This last slide just shows some of the unchanged criteria without refinement. So these exist exactly as they exist today under 2011 edition criteria. And here we have our med list, allergy list, drug to formulary checks, patient lists, advanced directives, again, inpatient only, as well as that optional accounting of disclosures criterion. So none of these have changed or have been refined. Next, we want to talk about the updates and revisions to the 2014 edition standards, so I'll go ahead and turn it back over to Amit. Okay, we're having just a couple of audio issues. While we are waiting for those to be resolved, we're going to go ahead and ask you just another polling question. So at this time, we want to go ahead and talk about public comments. And so we'd like you to tell us whether you have comments on the NPRM that you would like to share with us. We will be submitting public comments to the federal government. And if you have anything that you'd like to share with us, we'd be happy to include that in our comments. And so if you could go ahead and answer that question. Okay, great. So some no, a few yes. If you do have any questions or any comments that you'd like to share with us, we would like you to go ahead and send either Amit or I an email. And if you could do that before the end of this week, that would be helpful. And then we can include those in our own comments. Okay, and Amit, I think you might be ready at this time. Is that right?
Yeah, I think so. All right. And so to wrap up this presentation, one of the last sections I'm going to discuss right now is the 2014 edition standards that have been introduced or revised in this latest NPRM. So first off are the content exchange standards. In 2011, or the stage 1 testing, most of you are familiar with the requirements there, and most of the HL7 related procedures allowed an alternate standard. So the requirements were usually split between version 251 or version 231. What you'll see in the NPRM and the new proposals is convergence to HL7 251 for lab results, inbound lab results. This is a new thing, and there are specific implementation guides that are listed for each of the particular HL7 messages that are required. So for inbound lab results, this is a new one, a big new one, and the implementation guide reference there is the standards and interoperability framework Lab Results Interface, Release 1. And, when we talk about public comments, this is an area where I think some people may have a lot of interest in that this is a new implementation guide. It doesn't have a lot of use yet in production, but at the same time, the folks on the Standards and Interoperability Framework Group have been working very hard this last year to come up with this guide and get it ready in time for this stage 2. So if you haven't, you should take a look at that implementation guide and provide comments to ONC regarding its suitability. And even better, if you have the resources, get some people involved in that Standards and Interoperability Framework. The other implementation guides are the HL7 B251 implementation guide for immunization messages, the FIN messaging guide for syndromic surveillance, and the HL7251 implementation guide for electronic lab reporting to public health. Another new content exchange standard is a consolidated CDA. So folks that have been testing or are familiar with C32 or CDA, this shouldn't be a huge departure. And from all indications, the idea behind consolidated CDA is to consolidate the various templates in the CDA document to provide greater extensibility and provide a format for the patient summaries to transmit all of the various data that are related to meaningful use. So one of the big changes is going forward, the CCR and the CCD/C32 are no longer the specification. It's this consolidated CDA document. And so another item to note in public comments if you're going to comment on that. There's also a reference to the CDA document for reporting to cancer registries. This is another new proposal. The DICOM image is, or the DICOM standard is reference for imaging, which shouldn't be too much of a surprise. And there is a shift with e-prescribing, as Michelle mentioned earlier. Instead of NCPDP script 8.1, which is pretty much the industry standard right now, they are moving to 10.6. For vocabulary standards, there are a number of standards that have been referenced in the NPRM. Most of them are not a big surprise or out there. For lab, you have LINC version 2.38, medications, RX norm. Problems, only SNOMED, previously SNOMED or ICD-9 were allowed. Diagnoses, this is, ICD-10. Immunization, CBX, preferred language, ISO standard, preliminary cause of death, ICD-10 once again. Race, ethnicity, the OMB standard is previous, and the smoking status types set forth by the CDC. Transport standards, which is the slide I'm on now, is also a new introduction in the NPRM. And so here, for the first time, transport is being addressed. It was briefly mentioned in the stage 1 interim final rule, but removed completely in the final rule. And so there are a number of potential options specified. You have XDR, XDM, which folks who are familiar with the IHE work should be familiar with some of those technical profiles around direct messaging and reliable media. And then there is silk-based secure transport. And while they did not mention a specific RESTful option, they do allude to an implementation guide being available in the future, and that kind of leaves open the possibility for a RESTful option as well in the final rule. So again, this will be something that ONC is looking forward to having some comments on. And having worked in certification and testing, and particularly interoperability, transport standards is always a difficult item. And this may be the first time that I can remember where transport is ever being referenced in certification. So it should be interesting, though it'll still be a contentious topic. There are new functional standards that are also introduced in the NPRM. You have web content accessibility guidelines. You have the HL7 context-aware knowledge retrieval or info button. and the NQF, National Quality Forum Quality Data Model. All of these are, of course, subject to public comments, and I'm sure vendors will have comments one way or another on including these additional items. There are security standards referenced as well. For encryption, this time they reference FIPS 140-2, and there's also under security standardization under time and using the network time protocol. Folks who have, again, those of you who are familiar with IHE type testing, that's integrating the healthcare enterprise. Actually, just to back up a little bit, let me explain that. IHE is an organization that's affiliated with HIMSS, and they put on a testing event yearly. It's called the Connect-a-thon, and a number of vendors get together there yearly. It's in Chicago in January, and they work on interoperability testing using a number of proposed different frameworks. And you see some of these reference standards making their way into the final rule. If you've ever visited the HIMSS Health Conference and seen the interoperability showcase, many of the folks who are in that interoperability showcase start out by participating in the Connect-a-thon and practicing data exchange there and preparing for the HIMSS show. And so if you haven't been following IHE work, it may be something that you should be looking at, as they do have some influence in the process, and it's a way to stay up to date as far as where things are trending. And now finally, as we wrap up, we're a little bit over, and mostly due to my technical difficulties, so I apologize for that. I'm going to go over some of the next steps as we get into the final, the last couple months as we head into stage 2. So as the final rule is published, you'll see the sunsetting of the ONC ATCB certification program. And so we've included a nice graphic of a exotic island with a sunset, probably where we won't be, those of us on the certification and testing staff, because we'll be working with possibly you guys as we work on the next round of certification and testing. And so, as Michelle had mentioned, ICSA Labs is in the process of obtaining ANSI accreditation as a certification body, and separate accreditation by NIST, National Voluntary Lab Accreditation Program, as a testing lab. And so far, we've had our initial assessments, and everything's been going really well. So we anticipate being named in the permanent or the ONC EHR certification program. And as was with stage 1, we anticipate that there will be a rush for in the initial certification window for folks to begin certifying their products. And as customers of ours, we hope we can keep you informed and up to date leading up to the process, so that when it is time for certification, you can be as prepared, and we can help you in that preparation. So as I've mentioned a couple of times, public comments. So the deadline for that is May 7th. I do think it's important for everyone to take the opportunity to make their comments, especially if you feel strongly one way or the other about particular requirements. It's always one thing to complain about them, but it's also now an opportunity to influence the process to some degree. And whether you want to comment by yourself or piggyback on some of the comments we might be providing, we'd be happy to work with you along those lines. And so just to point out, here are a couple items that you may think about when considering public comments. So there are statements in the NPRM around adding criteria focused on the portability of data stored within a certified EHR technology. And I know that is part of the the whole objective and mission of Meaningful Use 2 is to make that data a little bit more liquid, and to provide the ability for folks to switch off EHRs if they find the one that they're using not to be the one that's going to take them to the next step. So portability of data is something that's lurking, right under these criteria. There are requirements around, or at least proposed requirements around certified EHR technologies providing some pricing transparency. And so, that's something folks who are selling commercial software may be thinking about. So another proposal was whether or not to make testing results reports public. From a testing body perspective, I mean, I can see both sides. For vendors and folks who go through our testing process, we pride ourselves on the confidentiality throughout the process, and we understand some of the intricacies and nuances around, developing products, bringing things to market, and instilling confidence in your customers. At the same time, certification traditionally is for purchasers of products to give them additional confidence when purchasing something that's certified that it does meet the required meet the various requirements. So I can see why they would want to propose this additional transparency. Then there's making the accounting of disclosures criterion mandatory, and adding criteria to require the recording of functional or behavioral, cognitive, or disability status of patients. And so once again, remember, as far as public comments, both positive and negative comments are welcome. And finally, here's a couple slides on how you can submit public comments. There's the federal e-rulemaking portal, regular mail, or hand delivery. And then finally, as we wrap up, I just wanted to mention that there are different ways you can work with ICSA Labs. You can stay up to date by monitoring the announcements we make. We'll be coming up with additional upcoming webinars on security, interoperability standards, and you'll have opportunities to collaborate with ICSA Labs and potentially pilot some of the 2014 edition test procedures. So that's an opportunity for you to get additional clarity on the testing process, procedures, criteria, and for us to provide more feedback to ONC. And finally, here are some additional references. If you go to the link that's provided on this slide, you'll see ONC's list of resources for meaningful use. And with that, I think we're ready to take any Q&A you might have.
Great, and as we're waiting for those questions to come through, just wanted to throw up just a couple more poll questions. And the first one is regarding the 2014 edition criteria. So it's assuming it is released this summer, again, that could be June, July, or August. When do you think that you would have your product ready to test against the new criteria, understanding that right now you're, basing this decision on the proposed criteria? It's not finalized at this point. Okay, great. So it looks like the majority of you think that if it's dropped sometime summer or late summer, that it would be probably November or later before you would want to do that testing, which is fine. The other question that we want to ask, I know Amit spoke briefly about pilot programs. I wanted to know if there's any interest in participating in the pilot program. This is an opportunity for you to sort of try out new criteria, give us feedback, and whether that's on proprietary programs by ICSA Labs or whether it is being a pilot tester for the Stage 2 2014 edition criteria. We're definitely interested in knowing your thoughts on that. It looks like about 60% of you are interested in that, and so for those of you that are interested, could you please send an email to Amit or I? We'll also be reaching out to everyone formally after the call in about a month or so, but if you are definitely interested, please reach out to us. Okay, so Amit, if you want to go ahead and look at some of the questions. I do have one question that came through regarding a dental group. So the question is, we are considered under the special category. Do we have a clear definition of what information we as dentists need to transmit and receive, or what categories we will receive exclusions on? And I believe that would be more related to the incentives of the criteria, and so we are still in the process of reviewing that NPRM and trying to get feedback from CMS on that, so we don't have a very specific answer for you at this point. So we'll certainly follow up, though, and make sure that we keep this on our to-do list. And any questions that we don't get to today, we certainly will make sure we send to you via email. All of the participants will sort of do a formal FAQ. We'll list out the question. We'll provide the answer. Okay, so the next question is related to new logos. Are there any new logos available now, or is that going to come at a later date? And so in answer to that question, that's going to come a bit later. The logos still need to be designed, and of course, right now, keep in mind that the proposed name of 2014 edition is simply proposed, and they may change that. So it's important that we wait to have any of those materials finalized until after the final rule has been published and we know for sure what that program is going to be called. So great question. So there's a question about being able to test in early May of this year, and someone wants to do complete EHR testing, and would that be under the temporary program or the 2011 edition criteria? And the answer to that would be yes, it will be under the 2011 edition criteria, which is the temporary program. Unless for some reason the final rule is dropped before May, which we sincerely doubt. They have been publicly saying summer of 2012, so we're assuming June, July, or August. So if you're testing in early May, there would be that would be tested under the 2011 criteria, which is the criteria that you've been using to test your system against. Okay, let's look at another criterion. The question is, if SNOMED CT is required for the problem list only, wouldn't that create problems with billing? And that's a great question, and certainly possibly, depending on how the system is set up. So that's definitely a great question and something that you might want to consider when you are formalizing the formal comments, the public comments that you want to submit to the ONC. There is a question about how, when, or where can we get a recording of the webinar? And for that question, we would simply tell you that we haven't yet decided that the recording is going to be public. However, we will certainly send out the slide deck, and as we make those decisions, we will notify everyone via email and send out any pertinent information for that. Okay, another question, is the requirement to store and display DICOM or to do single sign-on? Is single sign-on, is there a standard? So Amit or Kevin, I'll give you a moment to unmute, whichever of you would like to handle this question. So again, the question is the requirement to store and display DICOM or to do single sign-on?
Okay, so I wanted to make sure those were two separate questions or one single question, but I've been looking at some of the commentary in the public around the DICOM standard, and it looks like they are looking for additional clarity. So right now, the criteria is around being able to retrieve and access images using the DICOM standard, but folks have some questions around metadata and the information that needs to be submitted along with DICOM and things like that. So long story short, this is a criteria we need to find out more about. We have a number of meetings scheduled with the ONC and other ATCBs, and we'll be discussing some of that to the extent that we can. And I only say that because since this is a public comment period, ONC has some limitations on what they can actually say.
Great, thanks, Amit. And I don't see any other questions come through. I have received a question regarding the clinical quality measures, Amit, and that was via email prior to the call today. And the question is, do you have any sense of how clinical quality measures will be certified in the future?
Right, and so folks that have tested quality measures before probably, I know that I felt that we could have used an automated tool, and that was part of ONC's task list. And so they are working on automated tools around testing clinical quality measures and those calculations. There are two different projects that are going on. There's a project Pop Health and Project Cypress. They're both being done by MITRE Corporation in conjunction with ONC and CMS. And there are some pilot programs actually going on. So if folks are interested in testing or pilot testing or learning more about that, please contact us. But to the main question, ONC is piloting these tools. I don't know for certain whether they'll be required or not. At this point, without the pilot progressing further and without knowing exactly what would be in the test procedures, I would say I'd be expecting that it may be very similar to stage one. However, they are looking for adding some kind of tools to have a more automated test and to make the testing more robust. So long story short, again, I don't know for certain. I know that they do want to change the process and make it more robust. They are working on tools. If you want to pilot test any of these tools, please contact us. But I won't know for sure how they'll want to test those procedures until we get past this comment period.
Great, thank you. And the next question is related to GAP certification and whether GAP certification in the future would change the current practice of recertifying security and privacy criteria. Amit, are you still on the line?
Yeah, sorry. So with GAP testing and the privacy and security testing criteria, this is another one where we actually have some comments as well in terms of how ONC would prefer us to do the GAP testing. For those who have tested with us before or have done any modular testing, you know that the privacy and security criteria were all required for 2011. They may not be required for 2014 based on the new definition of the base EHR. However, as far as GAP testing, what we know is if the criteria hasn't been changed between 2011 and 2014, then it may be eligible for GAP testing. I think the thing that ONC and the various testing bodies are going to need to circle back on is to make sure that the process to identify GAP tests are similar across and inconsistent across the testing bodies.
Great. And then the next question is related to timelines, and the question is, can you explain when hospitals and eligible providers will theoretically begin to attest to the 2014 criteria? And this again is certification certainly impacts incentives and when hospitals and eligible providers have to attest to the new criteria for those specific incentives. And that's something that we are still reviewing and trying to get some feedback from CMS on. So this is a question that we will certainly address, but it will be a little bit later, not during this call. The next question, how will FIPS 140 really be supported? And the comment is there are 100 plus encryption modalities, none really interoperative. And Kevin, if you are able to handle that one, you may need to unmute yourself.
Well, I'm not sure if Kevin can speak on this call, but that's a good question. As far as how they're going to be testing it, we can propose test methodologies, but we won't know until the test procedures are published. So we can provide commentaries along with what you have suggested. We can provide commentary as far as suggestions on how to test it, but we don't know for sure yet.
Okay, great. Thank you. And I don't see any other questions. I'll give it just another moment. If you do have a question, feel free to click on the Q&A tab at the top of the screen and type your question in there. Okay, so I think that concludes our call today. Thank you so much for joining us. And again, we'll be following up with you after this session to either provide a link to a recording of the session or a link to the slide deck. And as always, we're here if you have questions either about current 2011 edition criteria or about the proposed changes.
And before we wrap up, I just wanted to add, like they say on the airlines, we know you have a choice when you decide to test and certify, so we appreciate you deciding to partner with ICSA Labs. And so as your certification and testing partner, we want to make sure that we can keep you up to date on the meaningful use and certification process as it progresses. And we'll be following up with you with additional informational webinars to provide a deeper dive on things like the security and privacy, certification testing and best practices, the standards of meaningful use 2014 around HL7 implementation guides, consolidated CDA, clinical quality measures, and usability. So keep monitoring your email, and we'll be in touch, and we look forward to working with you in the future.
Great, and as you're exiting, if you want to go ahead and respond to the last poll question about what types of webinars you'd like to hear from us in the future, looks like pretty much everyone is interested in all of these items: privacy and security, interop, clinical quality, pilot testing. So this will really help us gauge and plan for the next webinar for you.